Hey guys, welcome back. The next topic we're going to study is alcoholic liver disease. I'll be describing the spectrum ranging from fatty liver to alcoholic hepatitis and then the development of alcoholic cirrhosis. If it decompensates, patient will go into portal hypertension. But first of all, let's resolve this issue that what is the best test to identify alcoholic hepatitis? I know the fact that a lot of you will come up with answers like gamma GGTP. Some people will come up with the answer SGOT SGPT ratio. So let me resolve the controversy. Guys, in the exam, the wording of the question really matters. You have to understand the fact that if he begins by saying what is the best marker for alcohol consumption, why this question came up is because a lot of people might actually tell you the false information that I don't touch alcohol, whereas this guy is a big time alcoholic, or he thinks that he's not alcoholic because according to him is social drinking, though he goes out with his friends on a regular basis and he might be drinking 2 drinks a day, but he says I am not a regular drinker. So what test would you do for determining whether somebody is consuming substantial amounts of alcohol to contribute to damage? Because I'm going to tell you how much amount of alcohol, how many grams per day will contribute to development of liver damage. We will learn those facts subsequently, but at the moment I'm quoting the 20th edition of Harrison, page 3281, which categorically mentions that for alcohol consumption the marker is going to be gamma GGTP. Now, for those of you who were saying SGOT, SGPT for alcoholic hepatitis, yes, you guys are correct, because alcoholic hepatitis will take some time to develop. You see, first you have fatty liver. If a person will fatty liver will resolve, then if it does not quit, this fatty liver is going to get converted into alcoholic hepatitis. And the best test for determining alcoholic hepatitis, I'll show you the table from Harrison also, is SGOT SGPT ratio more than 1. Do remember the fact these both statements do not mean the same. In different years in the exam, they've asked these two different aspects, and what people are thinking is they're just focusing on this simple word alcoholism. Alcoholism is a broad term. It could be alcoholism, which simply implies that this guy is having a fatty liver at the moment, has not progressed to alcoholic hepatitis. And why is studying alcoholic hepatitis important? I mean, why are we studying this topic is primarily to understand that when it comes to alcoholic hepatitis, this is just before alcoholic cirrhosis. So if you intervene here, you can prevent, yes, you can prevent the degeneration into alcoholic cirrhosis by usage of steroids and pentoxifylline, and that's the basic objective. I mean, we need to recognize this stage so that we can take intervention, so that we can prevent the deterioration of the patient. Once I have resolved this issue, I hope it's very clear. If the MCQ says alcoholism, the answer is gamma GGTP. If it says alcoholic hepatitis, it does not mean the same. That means there's a definitive stage which is just below alcoholic cirrhosis and I want to intervene, then it is SGOT SGPT ratio. Having reiterated that, I want to contribute that the third largest disease contributor is alcohol. You very well know the contribution of coronary artery disease, which takes up the first spot, diabetes mellitus that takes up the second spot. I'm not incorporating COVID at the moment, which has reduced lifespan all across the world. But if I remove COVID from the discussion, then per se, CAD, diabetes and alcohol has big impact not only in India but even abroad, especially eastern part of Europe, Russia I'm talking about specifically, where vodka is consumed primarily because of, I would say, weather issues and cultural issues. So I mean, East Europe, Harrison mentions that, is worst afflicted by alcoholic liver disease. So this is third largest contributor of the disease burden. And we will now study how the manifestations will evolve in the patient. We will study the spectrum and then I'll show you the slides with respect to alcoholic hepatitis. Please remember that fatty liver caused by alcohol is reversible. Majority of patients, if you convince them properly, you see this patient is actually a young guy. He's 24-25 years of age. He just got a very good job in a IT company, and once money comes, partying also starts. When this guy goes to a party, when he goes to a bar, he might be thinking that he's drinking 1 beer a day, 2 beer a day, but gradually the amount of alcohol that he will imbibe will keep on increasing. He might think that he's keeping himself clean by not drinking alcohol for a few days, but most of the time you will find that the partying starts from weekends and gradually these people start partying on a regular basis, and the amount of alcohol consumed keeps on increasing every day to the level that he will say that earlier I used to wait for the weekend to actually go out with my friends and drink alcohol. Now all I think about is drinking alcohol all the time. It doesn't matter what time of the day it is. I just needed just to fix my nerves. So that kind of a deterioration, I think Honey Singh, the singer, is the best example that you can understand. He just rose to and shot to fame, and then obviously with fame came money, and with money came booze and expensive alcohol, and then you very well know that the way his career plunged down. So initially patients will be having fatty liver, and at this point of time, if you intervene, if you counsel them properly, there's a possibility that further deterioration can be prevented. And the further deterioration that I'm talking about is one step before alcoholic cirrhosis, that is development of alcoholic hepatitis. This is the point where you can intervene. From the histopathological perspective, they would love to ask you findings of alcoholic hepatitis. So since the hepatocytes are damaged, ballooning of hepatocytes would be present, and because I'm saying the word hepatitis, that means that there will also be inflammatory infiltrate present, so neutrophils would be present everywhere. There might even be evidence of spotty necrosis, and once the critical amount of spotty necrosis occurs, then subsequently the stellate cells in the liver will start becoming active. You see, initially the stellate cells, they're just passive, but once the damage crosses a particular threshold, but we're not able to determine or measure that amount of threshold. I mean, you can't predict if somebody is having alcoholic hepatitis, how many years will it take for deterioration into alcoholic cirrhosis. It will depend upon the gender of the patient, the amount of alcohol consumed, the quality of alcohol consumed, the concentration of alcohol consumed. So because there are so many factors that come up, it's very difficult to predict, but still studies have shown if somebody is having alcoholic hepatitis, there are 50% chances that he will definitely deteriorate into becoming a patient of alcoholic cirrhosis. And from here, it's a progressive downhill ride. Harrison quotes that people who are diagnosed with alcoholic cirrhosis, 60% mortality is there over the next 4 years. You don't need to remember the figures, but what I'm saying is, if alcoholic cirrhosis is determined to be present in a person, 60% mortality over the next 4 years is assured for this particular case. This is the precise reason why we want to intervene before, at the stage of alcoholic hepatitis, to prevent this degeneration. You will also be having fat deposition. I mean, this is a continuation, this is a spectrum. So I'm just mentioning that from the perspective of exam, he will write the word microvesicular and macrovesicular fat deposition. So you will obviously answer, and you know that from pathology also, that is, this would be a macrovesicular fat deposition, and later on there would also be cirrhosis, that is micro, and subsequently a macronodular cirrhosis. At this juncture, I also want to bring to your attention the presence of Mallory-Denk bodies. Now, they may not be visible on a low magnification, so you need to have a higher resolution image to be given to you in the exam. And let's just have a look at a couple of images which I think are important. At a low magnification, one, you can definitely see that this is the area where the fat has been washed off. So I can just say that at the moment, the image would be mainly in suggestion of presence of fatty liver in the patient. But on careful look, I will also notice some blue spots which are present here, that is neutrophilic infiltration. And if I just zoom it in, then in one of the hepatocytes, let me just bring it closer and then I'll mark it here so that it becomes easier for us to describe it. I mean, this is the hepatocyte that I'm talking about. I'll just remove the marking now. And inside it, you can notice this eosinophilic deposit, right? This is the Mallory-Denk bodies that I'm talking about, and the same Mallory-Denk bodies would be present at a higher magnification, seen subsequently as well. I will be comprising a list of conditions where Mallory-Hyaline or Mallory-Denk bodies are present. So if you're taking handmade notes, then please leave some space here. I'll fill it up in a while. But at the moment, I just want to go back to my previous slide and highlight this fact that what we are studying in the topic of alcoholic liver disease is actually a spectrum. You have first a fatty liver, then alcoholic hepatitis, and then subsequently a development of alcoholic cirrhosis in a patient. And Mallory-Denk bodies are like just one of the component. I mean, it's not that we will base our diagnosis only on the basis of Mallory-Denk bodies, because Mallory-Denk bodies can be found in so many conditions. So therefore, the question that arises is, what are the causes for it? And for this, I will be mentioning a mnemonic. Usually I do not recommend mnemonics per se, but here, since it's more of fact-based information, we can incorporate this. So the mnemonic to be remembered is, I will break alcohol status, and then just let us pick up words and also see that do you remember this from pathology. Alphabet I would be standing for Indian childhood cirrhosis. This is mainly due to cooking of food and storage of water or boiling of milk in copper utensils. This is excessive copper intake. In Wilson disease, there's definitely a different issue that the excretion of copper from the liver is defective. The biliary excretion is hampered, but here the dietary intake of copper is relatively more because the utensils are containing copper. It is brass utensils being used by poor families. W would stand for Wilson disease. B would stand for primary biliary cholangitis, and then they can deteriorate into primary biliary cirrhosis. There's a separate lecture on the same that I want you to remember. Then A would be standing for alcoholic hepatitis. That's the topic that we are studying. And when you focus on the word status, the alphabet S here would be for NASH. That would be non-alcoholic steatotic hepatitis, and obesity plays an important role in development of non-alcoholic steatotic hepatitis. The next query that will come in your mind after you have studied is how much of alcohol is required to actually cause all this damage. I mean, I'm talking about a spectrum. So after all, what would be the impact of consumption of alcohol and how many years will it take? So the answer will depend upon gender, and you very well know the fact that women have a higher chances of development of alcoholic liver disease even if they are imbibing lesser amount of alcohol. Let's see the differences. Clinical studies have shown, I'm quoting Harrison here, 40 to 80 grams of alcohol being consumed on a regular basis. Ethanol I'm talking about, right? Then the patient will end up with development of fatty liver. Listen to my next data, even with more care. If the same person starts consuming increased amount of alcohol, which will obviously happen over a period of time once the dependence component comes in, person is consuming 160 grams of alcohol per day over a period of something like 10 to 20 years. And this again is based on genetic predisposition, the body mass index of an individual, the way the person carries himself from the perspective of physical activity. I mean, is it a sedentary worker? Is it a moderate? Is he a person who regularly works out in a gym in spite of drinking alcohol on a regular basis, like some Hollywood actors, etc.? So, I mean, the progression will vary. But the point is, if a person is consuming 160 grams of alcohol on a daily basis, then this chap will definitely develop alcoholic hepatitis. I'm using short form AH, and then from there on, progression to alcoholic cirrhosis will occur. In comparison, when it comes to women, studies have shown that only 20 grams, you can see almost very substantial difference present here. Only 20 grams per day can cause progression into development of alcoholic liver disease. Why is it that women are more susceptible? One is that body mass index is lesser. So per unit body weight, alcohol will be having a more distribution. Apart from that, even hormones play an important role, that is estrogen. And the next point that I will say, I don't want you to note down, just listen to this. This is from Western studies. They say, like, in India, I will say women drinking will be lesser, prevalence wise as compared to Western community where drinking is a norm both for men and women. So what they've said is, like, women are relatively more responsible. That's a universally accepted fact. No gender bias there. I mean, women are more responsible, men are relatively less responsible. So if a woman is drunk, right, then she might decide to take some coffee just to get up her senses so that she can go to her job. And when it comes to a man, he will say, okay, fine, let me sleep and get over this hangover, or he might wake up with a hangover and he may decide to sleep again, not get over the hangover. He may not take coffee. So what they found was a very interesting observation, not that women are drinking more coffee or men are drinking more coffee. What I'm simply trying to say is, if a woman is more responsible, she is partly drunk but she still has to attend an important meeting, so she might try to sober up by consuming some amount of coffee. And studies have shown that regular intake of coffee is liver protective. Looks very surprising. I'm not saying that women will drink coffee, a man will not drink coffee. I'm not saying that, but they just said this, this is as a theory that, if a woman, she's responsible, she wants to go to a meeting and she's under the influence of alcohol, then if she sobers up with a strong coffee, then coffee has been shown to be liver protective. So progression of disease is relatively lesser in coffee consumers. So you can see the amount of factors that are coming in. My point is, earlier I was saying the fact that women are more susceptible, but at the same time I'm saying if the same person is a heavy coffee drinker, it might actually end up reducing the amount of liver damage in a patient, or it might increase the time span by which a person will end up with development of alcoholic hepatitis. This is the reason why, though we have been able to determine the amounts, there is so much of speculation. When you read the textbook, you start getting confused. Why? Because there are so many factors. Even coffee was one of the factors that is contributing to rather stopping the progression of the disease at the moment. Anyway, I would next like to mention that, like I said, coffee is good, but I want to say that hepatitis C, if present, then this would accelerate the progression of alcoholic hepatitis. Genetics, I anyway said, I mean that some people are heavy drinkers and they don't have a problem. Some people even at moderate amount of drinking progress to alcoholic cirrhosis relatively earlier. So genetics have a role. Obesity definitely plays a role in faster development of disease. Non-alcoholic fatty liver disease, all of these are rather gonna be, they are risk factors. They increase the progression to alcoholic hepatitis, in contrast to the intake of coffee, which I'm putting off the record. That's just one of the facts which is documented. It's written in Harrison. It's not that I'm saying it from research article, and there are articles related to that as well. But I just wanted you to be aware of that. But that does not mean that I mean you would advise alcoholic to drink coffee on a regular basis. There is no therapeutic dosage of coffee to be taken on a regular basis to neutralize the harmful effects of alcohol. It's just that it's an environmental factor that has been studied. So we will now focus on the clinical manifestations. A large number of patients will be in a denial mode. In fact, they drink heavily on a regular basis, but they are not ready to accept that they are alcoholics, and they might be even asymptomatic. But I have an individual who today came to me. Initially, he did not disclose that he's alcoholic. He just told me that, doctor, I'm having a right upper quadrant discomfort. He's also having complaints of nausea and vomiting. So I initially thought it could be viral hepatitis. However, I did not notice any jaundice in this patient, whereas in viral hepatitis, obviously jaundice would be present initially. When I did a physical examination, I noticed that his liver span was increased. In alcoholic cirrhosis, obviously the liver span will reduce and will become non-palpable. But initially, when a person is having alcoholic hepatitis, there will be a presence of a tender hepatomegaly. You will definitely have to pester the patient on a regular basis. He may not admit it initially that he does heavy alcohol intake. So a combination of heavy alcohol intake plus tender hepatomegaly definitely leads you to think in terms of alcoholic hepatitis, and you will be doing a workup of the patient. If the same patients come to you late, that's what happens in India most of the time, then you will be noticing that they will be first having features of compensated cirrhosis and then will go into decompensated cirrhosis. Compensated cirrhosis would mean I would be getting features like spider nevi or palmar erythema, Dupuytren's contracture coming up in this person. There might be temporal muscle wasting. There may be parotid gland enlargement. This temporal muscle wasting is again something I will say difficult to pick up in very skinny individuals. Proximal muscle wasting as well. But subsequently, as the disease will worsen, and it progresses towards portal hypertension, you will start having thrombocytopenia. I explained why thrombocytopenia, because when the spleen becomes bigger, there is hypersplenism. The appetite of the spleen increases. So you will notice that in patients having liver disease, platelet count usually is talked about in the discussion. Subsequently, there can even be a variceal bleed, caput medusae, evidence of collaterals developing in this individual. These are relatively late features. As I've highlighted, we would like to pick up the disease relatively early. So for the workup of this person, I ordered a liver function test, and let's look at some very interesting findings that I have found. The first and the foremost will be that SGOT of this patient will be elevated, even SGPT, but if you mathematically divide them, the ratio will be turning out to be more than 1. Suppose in multiple choice question, SGOT and SGPT are given separately. They're not given as SGOT divided by SGPT, but alone SGOT, SGPT separately. Then you will mark SGOT, and most of the time there will be about 2 to 7 times elevation found in the case. At this juncture, I want to tell you another interesting aspect. Listen to this with an open mind. If the MCQ simply says, what is the most specific liver function test? I repeat my statement. If the MCQ is not talking about alcohol, he is talking about the most specific liver function test, then your answer would be given as ALT. You know, L and L alphabet can definitely rhyme here. Your answer would be given as SGPT. Why is it that for alcohol you are answering SGOTs, not because O alphabet is common between SGOT and alcohol, but because of the location per se. You see, SGOT is present in the mitochondria of the hepatocyte, and that is where the alcohol is getting metabolized. That's where the enzyme called dehydrogenase would also be present. Whereas SGPT is present in the cytoplasm. So if you're having a cytopathic effect, if the hepatocyte is bursting, obviously SGPT values will increase. But if it is specifically a mitochondrial damage related to alcohol metabolism, because that's where SGOT is present. So definitely with respect to alcohol, I've provided to give you, or I have tried to give you a reason why, SGOT will be primarily elevated with respect to alcohol, and that's gonna be mainly with respect to the metabolism where it's occurring in the mitochondria primarily. So if you get a question with respect to alcoholic hepatitis, I reiterate my statement, do not answer gamma GGT. I'll show you a table from Harrison also just in a few seconds from now. Gamma GGTP is a non-specific marker for alcoholic hepatitis. I repeat the statement. It's a non-specific marker for alcoholic hepatitis. It can be induced by multiple factors. In fact, it is a marker for heavy alcohol intake, but it is never a marker per se with respect to alcoholic hepatitis. Then we will be performing ultrasound in the patient. There would be two reasons why I will be doing an ultrasound. One would be to check for the liver span, which initially will be increased and subsequently when cirrhosis will intervene will begin to reduce. I would also like to evaluate the echo texture of the liver. And if I switch on the Doppler in this patient, then why am I doing a Doppler is just to see, has portal hypertension intervened? Has this guy crossed over the threshold from alcoholic hepatitis to alcoholic cirrhosis, and that is beginning to deteriorate? Because then there is no point of treating him for alcoholic hepatitis. No, if somebody is deteriorated into alcoholic cirrhosis and then developing portal hypertension, I would be rather more specifically asking for an orthoptic liver transplantation. I would not be using steroids. So when I switch on the Doppler in a patient, and if I notice this report written, and this is itself an MCQ, portal vein flow reversal. This indicates the fact that portal hypertension has intervened. Obviously, with a Doppler, you can obviously be identifying the collaterals as well. The development of portal hypertension tells you the fact that there is no role of steroids and pentoxifylline for the patient. The subsequent test I'll be doing is a coagulogram. As is the norm in almost all liver diseases, prothrombin time is always deranged. The logic, I'll repeat once again, is factor 7, which is related to prothrombin time, has one of the shortest half-lives. I will also be doing a KFT in the patient since initially KFT can be normal, but then derangement can occur if the person goes and develops hepatorenal syndrome. That's a separate lecture in the app, and you can follow hepatorenal syndrome for the same, which is itself asked in detail and was asked in NEET PG 2021 as well. As far as the values of bilirubin are concerned, there is a possibility that bilirubin values will mostly remain normal or maybe borderline increase, but gross elevations of bilirubin are not found in patients of alcoholic hepatitis. Now, once I've done all these investigations, I'll not rush into doing a liver biopsy. Obviously, I can do a liver biopsy, but it is an invasive test. So there are a lot of other methods also available, non-invasive ones, before we tell a patient, okay, I want to do a liver biopsy. And one of the tests which has replaced liver biopsy, I'm not saying completely, but especially for alcoholic hepatitis, alcoholic fatty liver, we can be doing a test that is called as transient elastography. This imaging modality is a non-invasive method by which you can evaluate the echo texture of the liver. You can measure the amount of fibrosis developing in the liver, because you see fat versus hepatitis versus cirrhosis, each will be having a different echo texture. So if you fire a ultrasound beam into the liver, the speed with which it will travel with respect to steatosis versus fibrosis versus only hepatitis will definitely be different. And therefore, considering the difference, transient elastography is one of the methods that can be used for identification of these patients, and you may not have to do a liver biopsy. So I'm just putting 6 as liver biopsy, which is okay from a pathological domain, but in reality, I would definitely not like to do it. What I would like to do for the patient is, however, calculate what is called as a discriminant score or a discriminant function. The doctor who evaluated or first time made us aware of this score and its utilization was by the name of Madry. So name is Madry's discriminant function / score. Just you are aware of child park scoring with respect to cirrhosis. I'm talking about MADRS discriminant score for determining the severity of alcoholic hepatitis. You see, I want to intervene and prescribe steroids and pentoxifylline for the patient. So what I'm going to do is, obviously there are softwares available nowadays, so no worries. But then the mathematical formula is, and they'll ask you not this 4.6, but they'll ask you the parameters. The parameters are, one of the components is prothrombin time. You will be not putting the absolute prothrombin time value of the patient, but you will be putting how many seconds it is above the control. Like, you know, normal value is 11 to 16 seconds. Like, let's take an average of 14 or 15, and the actual value of the patient is 40 seconds. So it would be like 40 minus 14. That would be the rise above the normal that we are considering in this formula. And to this, I will be adding the bilirubin values of the patient. And you can understand that in alcoholic hepatitis, bilirubin values are normal, but when he progresses towards cirrhosis, when he progresses from, let me say, mild, moderate, severe alcoholic hepatitis towards development of cirrhosis, then the bilirubin values will start getting deranged. So what I can find in the patient will be that if the mathematical value turns out to be more than 32, this is one of the indicators for initiating treatment in alcoholic hepatitis, because if you do not intervene at this point of time, it's too late. Another way of intervention is the standard MELD score, model for end stage liver disease score, that I have described even with respect to fulminant hepatic failure. Before I jot down the value here, let's quickly revise what are the components of model for end stage liver disease. It would be serum bilirubin, international normalized ratio, and the third parameter here is serum creatinine. Once you remember the three parameters, I want you to remember that the cutoff beyond which you will initiate treatment is 21. Please remember the cutoffs for fulminant hepatic failure and deciding liver transplantation versus MELD score and decision for treatment for alcoholic hepatitis are separate issues. I mean, I get a lot of queries saying, sir, you have told a different value of MELD score for fulminant hepatic failure. That is for liver transplantation. Here, I'm not going for liver transplantation, man. What I am doing at the moment is going in for treatment for the person. In the exam, he's not going to ask you these cutoff values, but definitely what I want you to understand here is that whenever you read this term, MADRS discriminant function score, MELD score, they are telling you the fact, or they are utilized by you to determine that is alcoholic hepatitis developed in the first place. If yes, is it really that bad that the person will progress into cirrhosis? And then I told you mortality rates go up to 60%. I don't want to let that happen. So I will be rather using non-invasive methods for evaluating this patient along with the scores, and then subsequently the treatment of the patient can be done. As you know that there can be no dearth of information, so there is one more parameter that, or a score that I can introduce here before we go into the treatment part, and this is called as Glasgow Alcoholic Hepatitis Score. Now, why I have chosen to mention it is simply because you know that they can ask you about the Glasgow Coma Scale, and that's a standard in all the questions. So we will just be expanding our information here by studying regarding Glasgow Alcoholic Hepatitis Score. And here, not too much of work to be done actually. Serum bilirubin and INR is common in all the liver related scores, whether it be score related to MELD or whether it's going to be related to child park. I mean, ultimately serum bilirubin, INR, they definitely play an important role. But then an additional parameter which you have to remember over and above here, and I'm using a separate color to mention it, is age, then is blood urea nitrogen, and that is WBC count of the patient. So these are, I would say, three additional parameters or another score that is to be remembered. Let us now look at what is the treatment to be done for these patients. First of all, you have to tell the patient that you have to quit alcohol, because it does not make sense that he consumes alcohol and is taking treatment from you as well. So I would refer him to the psychiatry department, and they would definitely do a great job counseling this chap and put him on a de-addiction program. If they say that what drugs are recommended for de-addiction, then do not answer disulfiram. Disulfiram is mainly for alcohol craving. You very well know that from psychiatry. Alcohol craving, disulfiram. It will make the guy puke. But if you want to make him stop alcohol, and stopping alcohol is not like I'll decrease from one bottle to half bottle to quarter bottle and then move on to one beer a day. It's gonna be like total abstinence, and that will contribute to obviously alcohol withdrawal. So most people are not able to handle the symptoms of alcohol withdrawal. So that's why it is naltrexone and acamprosate that would be used so that the person can endure all that. And once he's clean, in a sense that he's off alcohol, we will be starting this individual on prednisolone. The main objective is to prevent the deterioration. You don't need to remember the dose. It is mainly to prevent the deterioration into alcoholic cirrhosis. So a 4 weeks course of steroids would be prescribed to this patient. Tumor necrosis factor alpha and its receptors also play a role. So therefore, the textbook says that inhibition of tumor necrosis factor alpha by usage of pentoxifylline also gives good results. In fact, some physicians prefer to use both of these drugs for the same duration to reduce the progression of the disease per se. But then from the exam perspective, first answer for you, whenever he says the word alcoholic hepatitis, would be prednisolone. If he says fatty liver, it is mainly abstinence, and fatty liver will reverse. We cannot predict because there are so many factors I told you, ranging from coffee to body mass index to estrogen, ethnicity of an individual, concomitant risk factors which I mentioned, ranging from hepatitis C to obesity, that will decide the progression of the disease. And that's why, I mean, initially, I can say that alcoholic hepatitis, when you read the topic, it looks like a very non-specific topic. But once you start reading the details, the technical ones that I mentioned, then it definitely makes sense. The evolution of the disease per se is what you really need to understand. Towards the end of the discussion, I'm showing you a table from Harrison. So let's just focus on this. This table specifically mentions regarding alcoholic fatty liver and alcoholic hepatitis, and mentions that the test to be done is SGOT. I've told you the values already, but I had to show you this table just to prove to you the fact that gamma GGTP, though it is a marker for heavy alcohol consumption, he mentions the fact that it is not specific to alcohol. It is easily inducible. It can be increased in all forms of fatty liver. Even it can be increased in patients on non-alcoholic steatotic hepatitis. So no big deal. And when it comes to bilirubin values, initially bilirubin values will be normal, but as they progress towards development of cirrhosis, then definitely the values of bilirubin can substantially increase. The second table from Harrison that I want you to remember is with respect to methods of assessing the liver from a non-invasive perspective. One of the important tests that I mentioned initially in alcoholic hepatitis was also transient elastography. When you send a shear wave or when you send an ultrasound wave through the liver, the speed with which it will be able to travel and the resistance it will encounter in fibrosis will be different from that of, I would say, a full-blown cirrhosis versus a person who's having steatosis. So different values are mentioned here for advanced fibrosis versus development of cirrhosis in a patient. Then we also are having blood tests available, like you will read about APRI. APRI would be AST and platelet count. Platelet count, why? Because I've explained, whenever there is hypersplenism, whenever there's a splenomegaly in portal hypertension, then the platelet count will definitely reduce, the ratio will increase. So by combination of these tests, like ELF would stand for enhanced liver fibrosis test. This liver panel test, if you write, then the laboratory will be doing the following parameter check: age, hyaluronic acid, MMP is metalloprotease 3, and TIMP1 is tissue inhibitor of metalloprotease 1. So these blood tests and obviously transient elastography are basically being done because we want to remove the distress that is associated with performing liver biopsy on our patient, and obviously the antecedental risks that can come. To finish this discussion, I would also like to remind you from the cardiology domain that if a guy is a heavy drinker and he goes on a holiday, he's a chronic alcoholic, his gamma GGT values are all spiking, and he has gone on a holiday where he's drinking large amount of alcohol, and it was initially like, on a party there was free alcohol available and he started binge drinking, then there can definitely be risk of sudden cardiac death, and that would be development of atrial fibrillation. And I would rate this as an important topic for the exam, alcoholic hepatitis overall, because alcohol per se is usually 2 to 3 questions on alcohol I usually find in various competitive exams, whether it be INISET or NEET PG or FMG exam. So if you listen to this discussion, I think that you will be able to improve your strike rate. And as I say, usually I'll repeat that again so that I can keep you pumped up and raring to go. So keep hammering, keep focusing, and you will definitely be able to achieve your desired goals and would be doing great in your careers. Keep the faith. Thank you so much for hearing me out.